Morning, good afternoon, good evening, everyone. I'm Dr. Milind Jambagi. I work as a pediatric intensivist in India at Rainbow Children's Hospital, and I'm a part of the WFPICCS Education Committee, and I'm the vice chair of the Education Committee currently. Unfortunately, Tracy Wolbrink, our chair of the Education Committee, was unable to join for the webinar today. And this webinar, called as Traveling Around the Global PICUs, has been an initiative of the WFPICCS Education Committee since past couple of years. And we do about one webinar every quarter, wherein we involve members from our PICU community around the globe and do great case presentations from different parts of the world and invite some expert speakers on that particular topic to share their insights and valuable inputs. So today, the topic is pediatric sepsis, which is one of the important causes of hospitalizations and morbidity and mortality in the world in children. And we have very eminent faculty here to enlighten us about the topic. So today I would first like to introduce our presenters and the trainees who are going to present their cases individually from their institutes. So first to go is Dr. Harshavardhan. He is the pediatric critical care trainee at Rainbow Children's Hospital, Secunderabad, India. And he has joined his training in about 6 months ago at Rainbow Children's Hospital, and he is going to present one of the cases of pediatric sepsis which their team has managed in their ICU. After that, we have Dr. Shannon Neland, who's also a pediatric critical care medicine trainee at Boston Children's Hospital and Harvard Medical School. And she has done her residency in Boston's combined residency program at Boston Children's and Boston Medical Center. And she has also done undergraduation in biomedical engineering, and she has done BSc in mathematics. And she has a master's in public health from Johns Hopkins University. And we have one more trainee from Boston, Dr. Carl Brito. He is a fellow in pediatric critical care at Boston Children's and currently working towards an academic career studying the immunobiology of pediatric infections and particularly in PICU. His main academic passion is to decrease the infection-related morbidity and mortality by leveraging the combination of clinical data, gene expression, and bioinformatic techniques. Then we have our experts and esteemed faculty. Dr. Preetham Kumar Padur. He is the director of pediatric intensive care and pediatric intensivist at Rainbow Children's Hospital, Secunderabad and Rainbow Children's Hospital, LB Nagar in Hyderabad. And he has a very vast experience of about 21 years in pediatric intensive care. And he has done his undergraduation from one of the largest medical colleges in Asia called Osmania Medical College, which has a huge pediatric wing as well, and he has about 40 to 45 publications in his name. He is also a teacher for the Indian Academy of Pediatrics Pediatric Critical Care Training Program. Dr. Adrienne Randolph is our faculty from the US, and she is a professor of anesthesia and pediatrics at Harvard Medical School and an attending physician in pediatric intensive care unit at Boston Children's Hospital, Massachusetts. She is the founder and the first chair of the Pediatric Acute Lung Injury and Sepsis Investigators Network, that's the PALISI network, a clinical research consortium of over 80 pediatric ICUs in the US and Canada. She is also a council member of the International Sepsis Forum and is active in the Society of Critical Care Medicine and the American Thoracic Society. She has published numerous multi-center trials, cohort studies, and clinical practice guidelines in the area of sepsis, ARDS, and management of acute lung failure in children. She has received multiple grants to study the life-threatening and fatal influenza infection and currently leads a 40-center Pediatric Critical Care Influenza Study Group. And then we have Professor Niranjan Kisun, who's our expert on the topic today, who's going to enlighten us about his expertise and talk about sepsis. So Dr. Niranjan is MBBS, FRCPC, FCCM, and he works at the University of British Columbia, BC Children's Hospital, and is the endowed chair in Acute and Critical Care Global Health. He is also the past president of the World Federation of Pediatric Critical and Intensive Care Societies, that's the WFPICCS, and professor of pediatrics and surgery and emergency medicine at the Department of Pediatrics at University of British Columbia in Vancouver. He is the president of the Global Sepsis Alliance and the co-chair of the Pediatric Surviving Sepsis campaign, as well as the vice president of the Canadian Sepsis Foundation. He is on the advisory board of multiple organizations, and he is the recipient of many awards and accolades, including Dr. Vidyasagar and Dr. Nagamani Dharmapuri Award for the sustained and exemplary pioneering achievements in the critically infants and children globally. He has also received the Golden Jubilee Oration 2015 Award for major contribution to pediatrics in India from PGI Mer Chandigarh in 2015. So thank you everyone for joining, and I'm humbled to have all of you for this webinar today, and thanks all the experts and presenters at the outset to join and to share your experiences. So let's start with Dr. Harshvardhan presenting his case.
Okay, hello everyone. Myself, Dr. Harshvardhan, training in the pediatric critical care, working in the Rainbow Children's Hospital, Secunderabad, which is located in the southern part of India. And I am working under Dr. Pritam Kumar sir, who is a consultant pediatric intensivist, Rainbow Children's Hospital, Secunderabad, India. So ours is a 110-bedded pediatric hospital with 14-bedded tertiary care PSU unit. They have approximately 4,000 hospital admissions per year with 900 PSU admissions. We provided services like round-the-clock child and transportation services and 24/7 pediatric intensivist cover, and we provide all modalities of ventilation, including HFOV, and we had a retinal dialysis unit, and we are doing plasmapheresis and renal replacement therapy. We had pediatric cardiac intensive care, neurocritical care, and pediatric surgical services, and oncological critical care services. Ours is a pediatric and pediatric critical care training institute, and we hospital is offering the PSU fellowship program for both doctors and nurses. So coming to the topic proper, it is a 3-year, 9-month-old child, previously healthy first-year child, born to non-consanguineously married parents, brought to emergency room with a pain in the right hip since 4 to 5 days, associated with restricted hip movements. Fever since 4 days, which is high grade, continuous, not associated with chills and rigors, rashes, bleeding manifestations, or burning maturation, not relieved with medication. And child complaining of loose stools since 1 day, multiple episodes, 6 to 8 episodes per day, watery, not associated with the blood or mucus. Child complaining of a dull activity since 1 day prior to admission. Initially, parents took their daughter to a nearby clinic where she was prescribed oral paracetamol, but symptoms didn't subside, and the parent brought her to Rainbow Children's Hospital, Secunderabad for further management. When the child came to her, child is sick looking with increased work of breathing, and child appears to be pale. So initial impression is child is unstable but not life-threatening. Coming to the primary assessment, her airway is clear. She is tachypneic with saturations maintaining 88 to 90% with room air, with reduced air entry on both sides, with the bilateral crepitations and breathe, and she has bilateral intercostal and subcostal recessions. She is tachycardic with hypotension, pulses are feeble, with the prolonged capillary refilling time with cold peripheries, and first and second heart sound were normal. Her GCS is around 12/15. Pupils are normal size reacting to light. She had hypoglycemia and skin color is pale. So our primary assessment is she's having primary cardiorespiratory dysfunction. She's having respiratory insufficiency in the form of respiratory distress and circulatory insufficiency in the form of hypotensive shock. So the issues were at admission, she's having hypotensive shock, respiratory distress, and hypoglycemia. Her vitals were she's febrile with 101 degree Fahrenheit. She's paler, no icterus, no cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Coming to secondary assessment, systematic examination, she's coming to respiratory system examination. She's tachypneic with intercostal and subcostal retractions with reduced air entry on both sides, with bilateral crepitations and with maintaining saturation 95% on oxygen support. Coming to the cardiovascular system examination, she had normal first and second heart sound, tachypneic with low cool peripheries, low pulse volume with a prolonged capillary refilling time and hypotension. For abdomen examination shows it is soft, distended, umbilicus is slit-like, liver palpable 4 centimeter under right coastal margin with liver span of 11 centimeter, spleen palpable 1 centimeter under left coastal margin with arm with presence of bowel sounds. CNS examination, she had a 12/15 of GCA, child is lethargic, pupils are normal size reacting to light, and there is no focal neurological deficit. Coming to the musculoskeletal system examination, she had restricted movements of her right lower limb, and she had redness and tenderness over right hip joint. So how we have managed in here, we have kept the child on oxygen support, and we have resuscitated with fluid boluses till 40 ml per kg, and we have given first dose of antibiotic, and we have shifted the child to pediatric ICU. In the meanwhile, we have got blood reports. It shows severe anemia with hemoglobin of 6.4, and the TC is very much elevated. It is 28,000 with neutrophilic predominance, and child has thrombocytopenia. CRP is very much elevated. It is 390. Procalcitonin levels are more than 100. Electrolytes were normal. Urea and creatinine were elevated with a deranged liver function test with normal coagulation. Child had severe metabolic acidosis with hyperlactatemia. Dengue and COVID serology were negative. An ultrasound chest shows bilateral pleural effusion. Ultrasound abdomen shows hepatosplenomegaly with increased renal cortical echogenicity as shown in the image on both sides. And ultrasound hip shows minimal right hip joint effusion with no sign of thickening on both either sides. So coming to the course in PSU, we have kept the child on piptide doxycycline on the day 1 of admission within the first hour of admission, because we have started injection doxycycline because we are seeing out of rickets cell cases in our area, which is close to sepsis, and her hemodynamics were unstable. So in spite of adequate fluid resuscitation, her tissue perfusion and hypotension not corrected. So we have started the child on injection adrenaline infusion at 0.1 microns per kg per minute. And in the meantime, she got central line and arterial line and urinary catheterization were placed, and her sensorium keeps on deteriorating. So we have intubated the child with a modified rapid sequence intubation in view of worsening of sensorium, worsening of respiratory distress, and fluid refractory shock. This is the child, and she's had hypocalcemia, and we have corrected that. And her hypertension is progressed, and we did a bedside echo, and it shows moderate to severe LV dysfunction with directed IVC. So we have started the child on dobutamine 10 microns per kg per minute. In the meantime, we have repeated the count. They showed severe hyperkalemia with potassium of 6.3, and ABG shows still metabolic acidosis with lactate decreased to 2.7. And she had severe anemia with elevated WBC counts. Platelet count seems to be dropped with a troponin I and pro-BNP levels are markedly elevated. So child is having hypoalbuminemia with albumin of 2.1. So we have given 20% albumin, and we have transfused IVIG for the severe myocarditis with elevated troponin I and pro-BNP levels with hypotension. And we have transfused PRBC 10 ml per kg for the severe anemia of hemoglobin 6.2 in order to improve tissue oxygenation with mid and end lattics. And we have given sodium bicarbonate injection for the acidosis and hyperkalemia. A child is having severe metabolic acidosis. It will blunt the catecholamine response to the myocardium. And the child is having persistent oliguria and fluid overload. So we have started the child on ASICS infusion, and the child BP seems to be dropped. So we have started the child on injection on infusion. So issues in the first 24 hours were worsening of PF ratios and oxygenation, increasing in the inotropic requirement, fluid overload, and acute kidney injury with the leukocytosis and falling trend in the platelet count, and hypoalbuminemia and hyperkalemia. So on the day 2, child is on mechanical ventilation and inotropic support with IV antibiotics. We have repeated the count. Hemoglobin after transfusion is 9.9 from 6.8, and her WBC and the platelet counts were reduced. CRP is gone up to 395. She had hyponatremia with hyperkalemia with persistent metabolic acidosis with elevated lactate levels and deranged renal parameters. Urine routine is normal. Her chest X shows bilateral heterogeneous carrier infiltrates on both sides. On day 2, in view of persistent shock, we have given injection hydrocortisone stress dose, and child is having persistent fever spikes with a rising CRP. So we have upgraded antibiotics to meropenem, and serum creatinine at admission were 2.2. It has gone up to 2.6 in 12 hours, and urea levels for 85 at admission. They have gone up to 117 after 12 hours. So child is having persistent fluid overload, worsening of kidney function test, and difficulty in ventilation, which is requiring more pressures to maintain adequate tidal volume. And child is having a persistent metabolic acidosis and blood gas analysis with hyponatremia and hyperkalemia. We have started the child on continuous kidney replacement with hemodialysis and continuous ultrafiltration. On day 3, child is on mechanical ventilation and on inotropes. Our lab values, the WBC is decreased, platelet counts were on decreasing trend, CRP levels coming down to 184, electrolytes were normal, urea creatinine were normal, LFT is mild deranged, and PT, APT, INR were mild coagulation profile is there. She has metabolic acids are corrected, lactate is 1.3, and her blood culture levels positive for MRSA, medicine resistant staph aureus. Her wheel Felix is negative. So child is having persistent fever specs on day 3, and blood culture shows MRSA, which issues culture. So we have added linezolid injection, and we have stopped doxycycline as a rickets cell infection. We are suspecting, and the scrub test is negative. Negative. Child had fluid overload of 68% with pulmonary edema changes. So we have continued continuous renal replacement therapy. Child had bleeding from NG and oral cavity, vitamin K and FFP transfused. So 12 hours later, so before starting the CR kidney replacement therapy, her creatinine levels were 2.6. So 24 hours later, they were dropped to 0.3. And blood urea levels were 117. After 12 hours, 24 hours, they became 22. And the issues we noticed on day 4 were she has persistent ventilator requirement, and her hemoglobin and platelets are dropping. And she's on kidney replacement therapy, and she had oliguria. She's passing urine, but is not able to achieve the urine output what we have wanted. And her fever spikes were reduced, and myocardial contractility is improved, and inotropes weren't appearing dose. So we have kept the diagnosis of severe sepsis with a multi-organ dysfunction, with a child is in encephalopathy with shock, with pulmonary edema, with ARDS. She had myocardial dysfunction with acute liver injury and acute kidney injury on kidney replacement therapy. She had coagulopathy also, and Phoenix score of 5 and SOFA score of 15. So on day 4, we have continued the child on mechanical ventilation and slow continuous ultrafiltration. We have achieved negative valence of 500 ml, but we have stopped ultrafiltration on end of the day 5. On day 6, we have again child had fluid overload, but there are no few spikes, and CRP and procalcitonin were decreased. So antibiotics were de-escalated. And on day 8, child continued on slow continuous ultrafiltration for the fluid overload. We have done child had hypertension with oliguria. So we have done renal Doppler, it is normal, and we have done renal biopsy also, it shows ATN changes. As an image, it shows renal Doppler shows normal flow with a normal resistive index and normal acceleration time. Here, peak systolic velocities are 50. Usually, it is in normal range. And child is on native balance. He is divulging spontaneously on the day 9. He have achieved native balance of kidney replacement therapy. But child has deranged liver function test and frequent hypoglycemias. So we have started the child on antifungal and glucose infusion rate. Child again had fever spikes on day 10 with a persistent thick secretions on the ventilator with chest X-ray changes. And also there is increase in ventilator requirements. So we are suspecting the ventilator associated pneumonia. And we have escalated the antibiotics. This hemoglobin, which on day 1 it is 6.4, we have transfused. And on day 4 it again 6.9 because of the coagulopathy and bleeding manifestation. We again transfused with packet RBC. And the CRP levels initial were 390, and they became 395 on day 2. We have escalated the antibiotics, and on day 3 we have got culture, so we added linezolid, and CRP levels are decreased, and we have de-escalated antibiotic on day 4. And on day 10, child again developed VAP, so we again escalate antibiotics. Platelet counts were 1.1 lakh initially, and they dropped to 38,000 on day 4, and they became 2 lakhs at admission. We didn't give any platelet transfusion throughout the hospital admission. And on day 2, child developed tension pneumothorax. She had sudden onset of bradycardia and desaturation. We have done bedside ultrasonography. It shows absence of lung sliding sign and barcode sign. So we have placed emergency tube thoracostomy. And in view of persistent and prolonged ventilator requirement, we have done tracheostomy for the child. And on day 4, her chest X showed fully expansion of lungs and no air column movement. So we have removed ICD drain. Child doesn't have any fever spikes on day 14, and sugars are also maintaining of IV fluid. And on day 16, we kept her child on CPAP and SAMV cycling, and we extubated the child to low flow on day 17, and we extubated off oxygen on day 18 of admission. She is in the ward for the 5 days, and she got discharged on day 23 of admission. So the take-home messages are the earlier recognition of shock is essential to prevent the child landing into the severe sepsis. And in hospital, we have to identify the danger signs of the sepsis, and we have to do emergency triaging to know the severity of sepsis. And we have to do early aggressive resuscitation and timely initiation of therapy if necessary, because for every hour of delay in the treatment, the mortality rate is substantially increased. And early aggressive resuscitation is also important because when the virus enters into the body, it causes systemic inflammatory response syndrome. It will produce inflammatory mediators, which causes organ dysfunction. So if you are giving antibiotics, it can cause a counter anti-inflammatory response syndrome. It will decrease the inflammatory mediators and it will limit the organ dysfunction, and it will cause boost up the recovery. And frequent monitoring of the child, because septic shock is a dynamic process. We are treating the child, we have to monitor for the continuous cardiorespiratory monitoring, including ABG bed gas analysis, arterial bed pressure monitoring, and advanced hemodynamic variables also if necessary. And health education is also important because in preventing the sepsis, because some of the people are uneducated, and some people, even though they are educated, they have lack of awareness about the danger signs of the sepsis, which causes delay in seeking the medical attention, which increases the mortality. So we have wanted to increase the health education by creating awareness among the healthcare workers also who are working in the periphery, so that they can identify the signs early and they can refer the child early to the tertiary care hospital. Thank you, everyone.
Yeah, hello everyone. Yeah, summarizing, I think it's a 3.5, 4-year-old child who's presented with sepsis, initially fever, and later on turned out to be MRSA sepsis secondary to the hip joint arthritis. So initially required resuscitation, fluid, then later on 9 drops, and child had cardiac dysfunction for when all these had to be treated, and then ultimately required CRRT, and then had to be later on developed BAP, had to be treated accordingly with an antibiotic escalation, then went. So
Thank you, Dr. Preetham. Shall we move on to the next presentation, and then we can discuss later again?
Hi, everyone. My name is Shannon Leland. I'm here with Carl Brito. He's one of my co-fellows. And then Dr. Adrian Randolph is our faculty expert. I'm excited to share this case with you today. So we currently practice at Boston Children's Hospital, which is a large quaternary center in Boston, Massachusetts, USA. Our hospital has 485 pediatric beds. 155 of those are pediatric ICU beds. And our ICU beds are divided into medical surgical beds with 81 of those, neonatal ICU beds, 30 of those, and cardiac ICU beds, 44 of those. We are considered a quaternary pediatric trauma center, and we share a helipad with our adjacent adult hospital. We're a large ECMO hospital and do about 40 cases per year. And we're a regional referral center for the majority of the Northeast United States. We also have a pediatric critical care fellowship program. So our case starts with an 11-year-old previously healthy female. She presented to a community hospital with fever, cough, congestion, sore throat, and respiratory distress. The community hospital is outside of Boston, about an hour and a half drive. It is a medium-sized community hospital with a 24/7 emergency department. It has adult and pediatric trauma capabilities and an inpatient pediatric floor, but no pediatric ICU. Her initial vital signs on arrival, she was febrile with a temperature of 39.1 degrees Celsius. She was tachycardic with a heart rate of 160. Blood pressure initially was 90/50, and she was tachypnic with a respiratory rate of 37 and a little bit hypoxic with a saturation of 91% on room air. Overall, she was fatigued and ill appearing. Her cardiac exam was notable for a regular rate and rhythm, no murmurs. Her cap refill was about 4 seconds, so a little bit of delayed perfusion in the extremities. She was tachypnic and noted to have increased workup breathing with subcostal and intercostal retractions, coarse breath sounds, and diminished aeration of her right lower lung field. The initial management, which was started in the community, she was found to be influenza A positive. They sent labs, including a venous blood gas, a complete blood count, chemistry, and blood culture. Those were notable for a metabolic acidosis with a pH of 7.3, a PCO2 of 32, and a bicarb of 15, as well as pretty significant leukopenia with a white blood cell count of 0.9. Her chest x-ray showed a right-sided infiltrate concerning for pneumonia. She received an IV fluid bolus, dexamethasone, and oseltamivir or Tamiflu for the influenza. She was placed on 100% oxygen via a non-rebreather mask, and the total fluid resuscitation that she received in the emergency department was 80 cc's per kilo of normal saline. At that point, the outside hospital initiated a call to Boston Children's and requested our transport team come and transfer the child from the community to Boston Children's. And we have a photo here of our transport team ambulance, which functions kind of as a mobile pediatric ICU and has the capabilities to do ECMO as well as any sort of intensive care therapies that would be offered in the community or at Children's. Next slide. When our critical care transport team arrived to the emergency department, they found that her exam had declined. She was fatigued with an altered mental status, now hypotensive with blood pressures 70s on 30s, and continued poor perfusion. They attempted to place the child on CPAP and BiPAP, but it was not tolerated. For the low blood pressure, she was started on an epinephrine infusion. And because of her altered mental status and progressive hypoxia as well as hypotension, the decision was made to intubate by our critical care transport team. They used a 5.0 ET tube, and she received midazolam, fentanyl, and rocuronium prior to intubation. After intubation, the critical care transport team titrates ventilator settings, and they have the ability to follow blood gases. And so prior to transport, she was on pressure control ventilation, 30 on 8 with a rate of 20 and 100% FiO2. When she arrived to Boston Children's in the medical surgical ICU, she was intubated, sedated, ill-appearing, again, decreased breath sounds on the right side, no murmurs on exam. Her abdomen was soft and no hepatomegaly. She had cool extremities with cap refill about 3 to 4 seconds. Repeat labs on admission now showed a mixed metabolic and respiratory acidosis with a pH of 7.15, a PCO2 of 55, and a bicarb of 16. Her white count remained leukopenic with a white blood cell count of 0.45. Her hemoglobin was 8.4 and her platelets were 132. Her lactic acid was elevated at 3.6. Her urea was 8.2 with a creatinine of 0.3. Liver function tests were within normal limits, and her CRP was elevated at 17.6. And a sputum culture preliminary was growing Staph aureus. Over her first night in the hospital, the providers escalated her conventional ventilator support, and she had ongoing hypoxia. They switched her to high-frequency oscillatory ventilation without much improvement and started to initiate discussions regarding cannulation to ECMO. So our assessment is an 11-year-old previously healthy female who was admitted with ARDS and septic shock in the setting of influenza A and Staph aureus bacterial pneumonia with impending veno-venous ECMO cannulation for hypoxemic respiratory failure. I'll pass it over to my colleague, Dr. Carl Brito, to complete the presentation.
Thanks, Shannon. Summing what we know so far, we decided to start antimicrobial therapy and also obtain source control. Our first line of intervention was oseltamivir, which we already initiated at the outside hospital. But given the Staph aureus, we presumed MRSA and empirically started on ceftriaxone, vancomycin, and clindamycin. And subsequently switched to ceftriaxone and ceftaroline based on our infectious disease recommendations. On hospital day 3, we noted bilateral pleural effusions, and these were drained with chest tubes. Over the course of ICU and hospital stay, a total duration of 21 days of antibiotics were administered to this patient. We also talked about fluid therapy, and over the course of initial resuscitation received 80 cc per kg of normal saline. We also started on pressors to initiate appropriate MAP goals. So she was on epinephrine, norepinephrine, and dopamine. And we had a arterial line which monitored her blood pressure throughout hospitalization. In terms of a ventilator management, in the setting of ongoing hypoxia and acidosis, the initial thought process was to switch to high frequency oscillatory ventilation, which is our general practice in our ICU. And due to difficulty in oxygenating even on high frequency ventilation, the decision was made to cannulate to ECMO, and we used the veno-venous route. And our faculty experts will go into the decisions regarding veno-venous versus veno-arterial cannulation. In terms of corticosteroids and endocrinology, she was started on stress dose steroids in admission. She was initially hypoglycemic, for which she was administered an insulin infusion. She remained NPO for 5 days until she was started on parenteral nutrition, and during these 5 days, she received dextrose-containing fluids. She received initial blood transfusions to maintain oxygen delivery on admission, and subsequently, after being cannulated, she received blood products based on our ECMO protocol to ensure hematocrit and her platelet count were within range to flow on ECMO. So to summarize our management based on various guidelines, which we know of, she was diagnosed with influenza, pneumonia, and had a super infection with MRSA. She received appropriate empiric antibiotics, which were then narrowed appropriately. We achieved source control using chest tubes to drain her empyema. She received appropriate fluid therapy in terms of rehydration and resuscitation. She was hemodynamically monitored invasively and continuously. She received appropriate vasoactive medications to titrate her MAP goals, and was ventilated initially via conventional means, and then high frequency and subsequently to ECMO. She received stress dose steroids. She received glucose control per our unit protocol. She was appropriately started on parenteral nutrition and received blood products and ECMO in order to clinically stabilize her. So her overall course was 7 days of extracorporeal membranous oxygenation therapy, 10 days of mechanical ventilation, which included both conventional and high frequency. She stayed in our ICU for 16 days in total, and her total duration in hospital was 25 days. She was discharged home and needed a visiting nurse to oversee the clonidine and methadone, which was administered to her outpatient as part of her rehabilitation, and she received physical therapy for activities of daily living. And 6 months later, she was back to baseline. I would turn it over to Dr. Randolph to summarize, and our faculty experts will take over the rest of the webinar.
Yes, so we have, I'm going to summarize very briefly, and then Dr. Kissoon is going to kind of compare the two cases and care delivery systems. But, you know, we have 2 cases here of very severe MRSA, you know, infection. And I'm just going to share in the chat this one case series that we published that's available open access, talking about vancomycin monotherapy potentially not being sufficient for optimal outcomes, because especially in the lung, it doesn't really penetrate very well in the lung. So we have been advocating for double coverage of these influenza MRSA co-infections, because they're the population in flu-infected patients who have the worst clinical outcomes in our influenza critical illness network. So I just wanted to share that tip or that article so people can make their own conclusions. I'm going to turn it over to Tex to summarize, and then we want to make sure we have enough time for questions.
Thanks very much, Adrian. And I'd like to congratulate the presenters. I think these are, as you can see, very difficult cases in different settings. But what I'd like to do, I'm not going to talk very much on the individual management. I think that would take days because there's a complexity of each one of the therapies that we give. But a few things that struck me listening to these cases. And one, the issue of the misdiagnosis early on in care. For instance, the one in India, this patient was seen at an institution 4 days previously, and obviously had signs and symptoms that were not really investigated at that time. And this is a very common problem worldwide. I think there are misdiagnoses in our settings in the developed world. Very clearly, that's a problem, but also misdiagnosis in the low and middle income countries. And what that translates into is late presentation for definitive care. And we saw that in the case in India. Now, so there are two aspects of the getting the patient early to care. And what we found is worldwide, globally, there is the issue of education of patients and families of what is sepsis. And I will give you one of the best, well, two best examples in the United States with intense sort of campaign from the Sepsis Alliance. The sort of public sort of understanding of sepsis went up from 16 to 66%. And in Germany, it's about the very same thing. In most countries, it's a lot lower. And I think there are studies from Africa, from South Asia, that shows that if patients and parents are not educated on sepsis, there's late presentation. Of course, there are other factors like transport, etc., to get to the hospital. But at the same time, what we find is that when they arrive at the hospital, there's education of staff in care of sepsis patients is lacking in many areas. And in fact, patients from studies from sub-Saharan Africa have shown that many of the deficiencies in care occur in hospital. And if we are going to make a difference in sepsis, we need to look at the hospitals also. So when it comes to education, and you'll see where I'm going with this, there is a very interesting study that was published in Lancet about a year ago, which showed that across the world, it was a large study looking at a large number of families. And they showed that if a mother completed high school education, her under 5 children has a 31% less chance of dying. And if the father completed the same education, it was 17%. It was a little different for neonates. But the general thing is that many of my colleagues across the world will tell you that education of families is a social vaccine. We like to prevent sepsis, okay? And education failure in healthcare workers is also a marked deficiency across the world. Now, so with that, I'd like to turn to a few things that to point out again, is one, the issue of approach to the resuscitation, the issue of fluids. And that's a very difficult issue. And in fact, it's going to go in a very much change. And in fact, a few weeks ago, I, among others, were at the WHO where we were discussing fluid requirements and those things. And it is the most contentious issue in sepsis, because when you are in a low resource setting and the low resource is defined that there is no access to intensive care services, you've got to be a lot more cautious with fluids. And even high resource settings now, we're saying that you need to be a lot more cautious with fluid. And the trend is earlier fluid, less fluid, and earlier inotropic support. And you can see the one that was transferred to Harvard eventually ended up with 80 mLs per kilo at the peripheral institution, which I can't judge whether it was the appropriate thing or not. So that's one thing, fluid. And as Adrian said already, we have to look very carefully at antimicrobial support and the local context. And in fact, that may be the most important thing to give very early on. I did not see timelines in both presentations, but that's very early because the largest study in pediatric sepsis in children, the study that was done in New York State, showed clearly that given the antimicrobial agents early as part of this bundle, but the antimicrobial agents itself decrease mortality. Now, what I'd like to pivot to, and I'd like to leave time for questions, so I'll try to be brief, is the role of the Global Sepsis Alliance. And what we did, recognition of sepsis as a major problem. Evelyn from the WFPICCS may remember in 2010, we, with WFPICCS and a group of international organizations, including the International Sepsis Forum, of which Adrian is on the council, started the Global Sepsis Alliance. And at the same time, we started World Sepsis Day because we recognized the importance worldwide. And where I'm going with this, I'll tell you a little of what we've done, but I really implore everyone to go on the site and join. It's free, and you can make contributions to sepsis worldwide because it's such an enormous problem. Remember the study we did through the Institute of Health Metrics and Evaluation, the Global Burden of Disease, showed that there were about 50,000 cases of sepsis worldwide. There were 50 million cases, 11 million deaths, and 85% of cases and deaths were in low middle income countries, especially in South Asia and Sub-Saharan Africa. So the GSA, what we've done is we started World Sepsis Day, which many of you know about. We've also went in 2017 and got to the United Nations World Health Assembly to get a resolution on sepsis. And the major aspects of the resolution really is based on infection prevention and control, is prevention, vaccines, water, sanitation, etc. One issue. Second thing is education of healthcare workers, which I mentioned before, education of patient and families, innovations and timely treatment, but also post-follow-up care. And I noticed both of these patients, in my estimation, would have some long-term problems because remember, 40% may come back to hospital within the 3 to 6 weeks or whatever, but also they would have ongoing cognitive and PTSD, etc., and need follow-up. In fact, our studies in Sub-Saharan Africa have shown that the same number of kids who die in hospital from sepsis, within 6 weeks to 6 months, the same number die outside. And we need to look at post care. So the GSA has worked with the United Nations. We're working with G7, G20. We're also working with the WHO. And if you go on the WHO website for the first time, there is now a page on sepsis with a lot of information there. There are now guidelines being developed. Many of you may be involved with the Pediatric Surviving Sepsis Campaign guideline. The WHO is doing sepsis guidelines for kids too. And the Society of Critical Care Medicine is now embarked on a Surviving Sepsis Campaign guideline for both adults and children in low resource settings. The other issue I'll stop after this is the Phoenix criteria. And many of you have heard about the Phoenix criteria. Now, the Phoenix criteria is what we have been done since 2018 with a group of experts across the world. We decided that we were going to relook on what is sepsis, what is the definition of sepsis. To cut a long story short, we got a bunch of experts. We got data from both low and high income countries. A massive study, the largest in the world, that I think is 3.6 million children, which yielded billions of data points. And what we did, we looked at the existing scores of what we use already. We had the international pediatric sepsis criteria of consensus criteria, of which again Adrian was very much instrumental in leading that. We had the PILOD score, the podium score. We have a PROL score, BSOFA, and vasoactive infusion score, etc. And of all these scores, we look for the criteria within these scores which are highly predictive of mortality between infection and non-infection. So in other words, we are looking at the best organ dysfunction score. Based on that, we looked at the various target organs, and then we formulated the PHOENIX criteria. And what we found, we can have the most, we wanted to get a criteria that was that can be used both in low and high income countries. And we found that cardiovascular, respiratory, coagulating, and neurologic, those 4 organs give us a robust enough score, and they were better than any of the other scores. Does not mean that the other organs like renal, liver, etc. is not important. But with these 4 scores, you can identify patients with sepsis. But the PHOENIX criteria is an advance for us, but it has its warts. One, we cannot use it for early sepsis. It does not really give us a method of screening, etc. in early sepsis, and there's work ongoing that will take care of that. It is very good for enrolling patients in studies and looking at epidemiological studies, etc. So at the present time, you will hear about the PHOENIX criteria. It's the best we have right now, but there will be ongoing work for that to really answer some of the questions. And you will hear over a period of time more talks about the deficiencies of the PHOENIX criteria and what we're trying to do about it. I'll stop there and I'll turn it off to Adrian.
Great. I think I'm going to turn it over to Dr. Jambagi to pull up some of the questions he's been collating, and then we can try to answer them, Tex and I and the rest of the group, Dr. Preetam.
Yeah. So I'll try to pull out the questions from the chat box for our experts. So I think one of the questions, I mean, a couple of them have been already answered by Carl and Harsha regarding their cases and presentations. And there's one question by Mercy, who wants to ask, is there a role of blood transfusion for the management of refractory septic shock? And can blood assist in getting a patient out of shock?
Well, that's a very good question. And there really isn't a really clear answer because there's never been a randomized trial in shock. There is the criteria that are international called the TAXI criteria. I'm trying to remember the name of what it stands for, but the TAXI criteria discusses this at length, and this is the one population of patients that they did not recommend, they could not make a recommendation based on evidence, is the ones in septic shock as to what should be the hemoglobin target. There really is not evidence that you must aggressively transfuse, and in fact, in adults, there's evidence that high hemoglobin targets are not necessarily helpful, targeting a very high hemoglobin, but how low of a hemoglobin to tolerate is unclear. That do you have anything to add, Dr. Preetam?
Sorry, we generally transfuse below 7, but if it is above 7, generally don't transfuse unless it has any other reason why is bleeding, especially more so in dengue and all those the situations what we see where we see a lot of these children bleeding continuously. That is where probably we go for a little higher threshold where we just try to maintain around 10. But otherwise, most of the sepsis, we would leave 7.
Okay, dengue with the drop in your hematocrit is one scenario where you would like to transfuse your red blood cells.
Yeah.
So
I think-
we'll jump. Yeah, sorry.
Yeah, I think Adrian is right. The study that look at critically ill children, not specifically sepsis, the Jacques Lacroix study showed that if a patient is stable, critically ill but stable, and you're not changing ventilator up and down or inotropes up and down and those sort of things, then you can let the hemoglobin drift down to about 7, and that's probably okay. But if they're unstable, you need to transfuse them up and they give 10, but not for sepsis only. I think the issue that plagues a lot of the world in low and middle income countries is the issue of the kid who comes in like malaria. Invariably, many of these kids are anemic with a hemoglobin of 4 or 5. And I think that that's where they may require blood transfusion a lot earlier than most kids, because if you give them fluid only, you're going to dilute them further and may put them into further trouble.
Yeah. So we have another question from Dr. Ramesh Bhatt. What is the maximum adrenaline dose initially before you add on noradrenaline or dopamine? And he has a follow-up question. How long one can use, it's another question, how long one can use stress dose steroids in such infection-induced critical scenario? So we'll go one by one. So what is the maximum adrenaline dose initially before you add NORAD or dopamine?
Well, I think that is also another area where it hasn't been rigorously studied and there's practice variability. Some people add it early, and some people, so others wait until you get up to like a level of 1 mic per kilo per minute, and then start a second pressor. There really is no clear guidance on exactly what to do, except that if you have myocardial dysfunction, that you should give pressors that are going to help with the myocardial dysfunction and not just necessarily norepi. So that's the one caveat in the guidelines, surviving sepsis guidelines. And they also do deal with the duration of steroids question in the surviving sepsis guidelines. They talk a bit about what's known and not known, and that you can turn off the stress dose steroids as soon as the patient's out of shock, that you shouldn't prolong the stress dose steroids unless you think the patient's adrenally insufficient at baseline.
Some out of text, you want to add anything?
No, I agree with that. I don't think there's any more to add. I think the choice of inotropes right now is still in flux, but it depends on not only the personal preference, but assessment of the patient at the bedside, because shock is something that is so dynamic that they may change from one sort of aspect of shock. There may be myocardial dysfunction. You may treat this and then have peripheral vasoconstriction as a major issue, and vice versa. And sure, we cannot rely on the clinical assessment of warm and cold shock with any great fidelity. But I think the key with shock and titration is continuous assessment of the patient and titrating with the drugs that you are familiar and you know the side effects and those things.
We have another question from Ivani. He is asking, is insulin advised for hyperglycemia in sepsis?
Dr. Preetam, do you want to answer that one? I don't want to put you on the spot. Yeah.
Thank you. Shivani, I think there's no right answer, wrong answer, but at least we just want to maintain it somewhere around 180 or less than 200, because I think, if I'm not wrong, I think there was a study published long ago that it showed that the higher the sugar, probably the bad was the outcome. So I think that's where the level of 180 or 200 came in. If I'm wrong, I think Professor Adrian and can correct me.
Yeah. Well, Michael Agus is an endocrinologist and a critical care doctor, and he did a trial, but not just sepsis. It was all patients, called Half Pint, and it was tight control 80 to 110 versus 140 to 180, and the 80 to 110 had a lot of hypoglycemia and not any better outcomes. So they basically said tight control in the low range was not beneficial and could be harmful. But nobody wants them staying above 200 for a long time, because that could also be harmful. So it's sort of you keeping them in there less than 180, less than 200, but not trying to get tight control at the low end of the range.
One more question, I think, for Carl and Shannon. Why was midazolam and fentanyl given in your during your transport if the child was so hypotensive? Do you think?
Yeah, so usually our transport team has a protocol which they use and they follow, and fentanyl is quite blood pressure neutral. I wasn't on the transport call, so I can't answer that question in terms of what their decision at that point was. But our transport team usually goes to a resource limit. I won't say limited, but they're slightly less resourced than us at Boston Children's, and sometimes they use whatever they have in terms of getting the patient intubated quickly and then transporting them as soon as possible. Fentanyl is usually our go-to for most of our patients on the transport side of things. But I don't have a good answer for why midazolam was used. I don't know if Shannon has more insight in that.
No, I think with our intubation sometimes do like a small dose of midazolam followed by a dose of fentanyl and then rocuronium. That's a pretty standard combination for intubation medications for us.
Who wants to ask a question? Transitive pleural effusions are known in influenza, and in the Boston Children's case where the effusions proven as exudative before the ICD placement, and should bilateral minimal transient effusions always be tapped?
So what was the question? Should bilateral? Sorry, go ahead, Adrian.
Oh, I read the question. So this patient had a necrotizing pneumonia and pus with exudative effusion that was large, and source control is one of the key factors in sepsis, and especially if you have a pocket of pus, to drain it is really important to accelerate recovery, because it's hard for antibiotics and things to get in and kill the organism in that walled off space. And it also can then cause worsening of the necrotizing pneumonia. This patient did have pus, an exudative effusion, and it was large. But the small transudative effusions don't necessarily have to be drained. They shouldn't necessarily be drained. But if someone has a bacterial infection, then, and you have it's important to ensure that it's not an exudative infusion, it's not pus, because those do need to be drained.
Mhm. No, thanks, Adrian. I think that's a very important point. And I think that one of the issues I see when it comes to different resources, in many places, they do not have access to surgical services. And you may find that a patient has an intra-abdominal abscess, etc., and treating with antibiotics only, mostly, in fact, in most cases, will ensure a very poor outcome. So I think I agree with Adrian that we need to stress that more and more, the issue of source control, getting rid of buckets of pus wherever they are.
So Mohammed had a question for Harsha. Why did you use doxycycline for the patient you had in the first go? Yeah, Dr. Harsha, would you want to stress? I think you already answered it. Do you want to just answer it for the sake of larger audience once again?
Yes, sir. As in India, our locality is endemic to rickettsial infection. We see a lot of rickettsial cases in our area, which are closely mixed to the sepsis. So we have started by giving injection on day one itself. Once the Will-Felix reaction test report came negative, we have stopped that antibiotic.
Yes.
So, Harsha.
Sorry, yes.
Yeah, Harsha,
Sir.
you made a statement there, and I think that we need to change that thought because rickettsia causes sepsis. It's not like sepsis. And I think that's one of the issues we've had worldwide, the issue of saying, well, this patient has some disease, but an infection that leads to organ dysfunction is sepsis. Okay, and I think that's what we're trying to change across the world, that we need as health professionals to shout it from the rooftop, that any infection that leads to organ dysfunction that may lead to death and disability is sepsis. So it's not like.
Yes, okay, sir.
So Khushbu, Dr. Khushbu has another question. Your experience using any other antiviral agent in severe influenza ARDS? Dr. Adrian or Dr. Preetham?
Yeah. So there's a randomized trial right now for influenza in the REMAP-CAP, which is the platform trial that so not everybody uses oseltamivir even in influenza. It's variable across countries. There really was never a randomized trial proving in these severe cases in the ICU that it's necessarily saving lives. It's good at preventing worsening of influenza, but once they get bad influenza pneumonia, there was not clear evidence. So there's a randomized trial in adults, and now they added children that mostly start in the UK at the moment, but it's going to be international, of oseltamivir plus baloxavir, oseltamivir versus placebo, et cetera, in this platform trial. Peramivir has to be IV, I believe, and has some toxicities as well. We used it in the 2009 pandemic in a study looking at dosing, et cetera, but it's not widely used. It's good if you have resistant influenza that's resistant to oseltamivir. We have used it sometimes, especially in patients who are immune compromised or have very severe flu that is not improving.
So you would use oseltamivir anyways at the first go, and then I'm not sure if all the other drugs, other antivirals are available widely in other countries.
Yeah, I mean, it's only oseltamivir, peramivir. Baloxavir really was only studied in outpatients, and it's both oseltamivir and baloxavir are enteral. So they have to be metabolizing. Peramivir is good if you can't be, the gut, you don't think the patient's going to absorb the drug, then peramivir is an option if it's available. But otherwise, there's really nothing else for influenza that has been shown that I know of to be beneficial as an antiviral.
Move on to the next question. Dr. Shalu has a question. The sepsis 3 criteria highlighted PSOFA score and now Phoenix criteria. What is the correlation between what is the correlation between these two scores, and what is the clinical correlate between the two scores? Dr. Tex, do you want to take
When
this?
we say two scores, I think that the PSOFA score uses the cardiovascular, respiratory, neurological sort of limits that is appropriate, age appropriate for children. Now, so as I said before, we chose the best sort of organ dysfunction score from those, which is with the highest mortality. But at the end of it, when we generated the Phoenix criteria, we then look at the area under the predictive curve, right? To look at how the Phoenix criteria compares with each one of these scores. Okay, and the Phoenix criteria is far superior to every one of these scores, the IPPC, the PLOD score, the podium, the PROL, and the PSOFA. So what we're saying is that if you have a score that you're looking at to really identify sepsis, the PSOFA is less reliable than the Phoenix criteria. But again, as I said, we got to be very careful that right now the Phoenix criteria does not identify or help you in identifying early sepsis. We are working on some criteria for that because, and it is relevant in many parts of the world, especially when you have low resources. You have to go upstream. You cannot wait till the signs and symptoms of sepsis are very obvious. And in fact, a saying was made by Machiavelli in his book, The Prince. He was speaking about countries in turmoil, but he equated it with hectic fever, which is sepsis. And what he said was, in the early stages, countries in turmoil like hectic fever, it is difficult to recognize, but easy to suppress. In the late stages, it is very easy to recognize, but very difficult to suppress. And I think that that's where we're going with here. We need to go upstream now and do the work such that we can get sort of earlier methods of diagnosis. I mean, the other thing with the Phoenix score, we really don't have really a diagnosis of sepsis, because what we are doing is saying that this group of patients have a higher risk of mortality, and these are the ones we're saying that we should attend to in a more sort of a rigorous and timely fashion. And there are a lot of work going ahead and thought about getting the molecular markers, RNA and DNA signals of the various organisms, which would probably get us closer to the diagnosis, because blood cultures, you may be 10 or 15% across the world and those things, and many are viral infections. So it may sound a little strange, but we really don't have a diagnosis of sepsis. We have risk scores that patients with infection has these risks of dying. And I think that's some work we have to do.
So agree. I think the Phoenix sepsis criteria is has more something to do with early identification and screening of children with sepsis, so that resource limited settings and smaller units, healthcare setups would be able to pick up the children with sepsis earlier. That is what I think is the idea behind this Phoenix score. So we have one more question. Yeah.
So the Phoenix score, if you have 2 points on the Phoenix score, you have sepsis.
Yeah.
And if you have these 2 points plus 1 in cardiovascular, then it is septic shock.
Septic shock.
That's a simple sort of thing. Okay.
So Dr. Dayanand has a question. What was the time of baby arriving to tertiary care center from the onset of illness? It's very important that focus of infection was obviously in hip, and why not anti-staph antibiotic was chosen instead of doxy and vanco, and whether baby had any admission in hospital in the last 6 weeks. So I think Dr. Harsha has already answered it. We'll go for the next question. Could linezolid be considered over vancomycin in MRSA when lung is the primary focus of sepsis? Dr. Kushbu wants to ask. And Dr. Arun Bansal, who is one of our senior pediatricians and pediatric intensivists in India, has tried to answer, and he says linezolid is bacteriostatic and not recommended for these. And for MRSA, vancomycin is a drug of choice. I think that's what we all do. So Dr. Lincoln wants to ask, please comment on the use of dopamine in sepsis.
No, it's good to see Lincoln on. Lincoln, I haven't seen you in decades, but wonderful to see you around. For everyone who don't know, Lincoln works in South Africa. Okay, I think it's Bloemfontein. If you look at the iterations of the Surviving Sepsis campaign guideline, early on, you will see that dopamine was a drug that was recommended, okay, as the first line agent. And I think in those days, it was more based on the fact that dopamine was available all over the world. Many people knew how to use it, and it was cheaper. But then there were a few studies that came about that showed that, well, maybe dopamine is not the best drug. And I think one of the study obviously was the one from Latin America by, blanking on the name now, but Andrea and can't remember what's her name, where she basically showed that with dopamine compared to epinephrine, Andrea Ventura, thanks Roberto, there was more risk of infection and there was less resolution of organ dysfunction or more organ dysfunction. So it seems that epinephrine was superior to that. And over the years, you look at the guidelines, we then recommended epinephrine as a first-line drug. And then we recommended the second-line drug as norepinephrine. Now, we realize that dopamine is still available in some parts of the world, but if given a choice, we would suggest that epinephrine be the first-line drug. And I know there's some ongoing debate and studies as to the role of dopamine, but I think we have to be pragmatic too. So Lincoln, I hope that answers your question, because it is still used in many parts of the world. If that's a drug you have and you know how to use it, that's fine. But I think ideally, if you can get epinephrine, that would be better.
One more important question. Subayan Mukherjee wants to ask, role of IVIG and its indications in sepsis and septic shock.
That's a good question. And it's a bit, right now, the Surviving Sepsis Guidelines did review all the evidence around IVIG. It's those data, the Surviving Sepsis Guidelines are being updated. There's a group working on revising and updating them. But there is not good, strong evidence in general to give IVIG in general for septic patients, that it improves outcomes. So as a general rule, there's always some patients who may be IVIG deficient at baseline, who definitely would benefit, and possibly for certain types of infections, there may be like toxic that create toxins, like toxic shock type infections. But as a general rule, for all cause sepsis, it's not recommended.
Yeah, agreed. It's not ready for prime time as yet. I know there's some work being done. I think that being done by Mark Hall, looking at the stage, because as I said, sepsis change, the physiology changes. So you may have the aggressive inflammatory response, and you have the counter-inflammatory response and those sort of things. So it depends on whether the patient is really hyperimmune or hypoimmune, and then there may be roles for IVIG, etc. But that's not ready for prime time. It's just we don't know as yet, and it's only being done experimentally right now.
So I have a question, Dr. Tex and the experts. Do we really? I mean, do you have to further investigate if you're suspecting any cytokine storm, and then take a call about IVIG in such cases?
Sorry, cytokine storm and.
I mean, if you want to decide about the use of IVIG in children with sepsis, and then.
Well, that's the work I'm telling you about. I think there are some people who are just skeptical about the cytokine storm, but I think it is recognized that they're either in the same patient or in different patients. You may have a patient who comes in with the massive immune response, okay? That we say the dysregulated immune response, okay? But at the same time, you may have timeline with this patient, a week down the line or something, they may be hypoimmune, right? And that's the time when immunoglobulins may work. It may not work in the early stages because that's where you get secondary infection, etc. So it's really judging where the patient is. And I think that's what I'm saying is, as Adrian said, we're looking at the guidelines again, but I don't think there is enough evidence one way or the other. And there is not enough laboratories in the world, I think, that can measure the parameters to determine that, yes, this patient should get IVIG or this patient should not. But I think over the years, we'll have more and more information on that.
Just the one question there about anakinra, that's another sort of related immune modulation. So Mark Hall, who's at Nationwide Children's and studies this immune paralysis quite extensively. There is a trial, Pediatric Critical Care Medicine, the WFPICCS journal has the outline of the trial called PRECISE. It has two arms. One is GM-CSF if the patient has immune paralysis, and the other is anakinra if the patient has hyperinflammation and not immune paralysis. And it's ongoing now at a lot of sites. I believe it's Canada and the US. I know it's at least the US, funded by NIH, and it could also be spreading to other countries, the trial, to get enough patients. But it's hopefully we'll have some answers about whether it's beneficial. But the design of the trial was published like 6 months ago in Pediatric Critical Care Medicine.
Yeah, and Mark also have, if you guys have access to Open Pediatrics, Mark has a talk on Open Pediatrics recently, I think, where he discussed the trial and discussed the both groups and those things. So I think if you would like to get more on that, just go to Open Pediatrics and look for Mark Hall's interview.
So there is one question about the diagnostic part. What is the role of BioFire panel compared to conventional blood cultures in diagnosis of the bug in septic shock in view of growing availability of these type of tests? So it's about the BioFire and comparison between BioFire and blood cultures.
The
What is
BioFire,
BioFire?
yeah, for
Yeah, what is it?
respiratory, yeah, it's it's only a respiratory panel
Mm.
for BioFire. It has viral panel and it has a bacterial panel, but it's from respiratory source. Yeah. Versus, you know, the blood source, there's there's a Carious test that's very expensive that looks at DNA of organisms, whether they're the organism's dead or alive. It'll pick up the DNA, and that would be a highly, highly sensitive, but sometimes false positive test for identifying organisms in the blood.
Yeah, so the BioFire panels which are available in India, actually they're very costly. And as Dr. Adrian rightly said, they detect all the dead bacteria and the DNA of the dead bacteria, which might be a problem actually in treating your cases. So yeah, I think we are pretty much done with the questions. So any other questions? We'll have a couple of minutes and then we'll wind up.
I mean, just one added thing about the BioFire. So it is costly. Even here, they charge at least $220 per test, which is huge. It's very expensive. So, but the thing is that most of those viruses on the BioFire panel, there's no treatment for them. The ones that are treatable are COVID and influenza. So at least at our center, we only test for COVID, RSV, and influenza. There's panels that are much cheaper that just test for the things that, you know, might be important. And two of those would change your management that you would treat with antivirals. And then as far as the bacterial panel they sell, it's also very expensive and it hasn't been tested well in children as far as I know, as to whether it changes outcome, whether this is true infection versus just detecting the bacteria, because they're very sensitive. So they'll detect a bacteria at a very low level.
One more question from Dr. Kushbu again. So I think there are many other drugs which have been tried earlier, like vitamin C and then methylene blue in sepsis and septic shock. So Dr. Kushbu has a question regarding methylene blue in catecholamine refractory septic shock. What's your experience about using methylene blue?
Yeah, I'll let somebody else answer that in case they might use it. We're not allowed to use it IV except in very rare cases, so we wouldn't use it in catecholamine refractory at our hospital because there's some side effects and toxicities to the methylene blue.
Last question. Dr. I think Roberto wants to ask, what do you think about the echograph guided management of septic shock?
I think it depends. It depends on whose hands you have doing the echocardiograph. I think it is useful, and I know echocardiography has been done in the EDs, and it's done in a variety of settings now because it's very inexpensive to get equipment. But I think the training is important too. I think in sepsis, my impression is that you're looking for crude changes. You're looking for things like, is the contractility normal or abnormal? Because as an intensive care or emergency physician, unless you've been trained in it, the the subtleties are very difficult to understand. I know that there are training programs through the Society of Critical Care Medicine, and I think other societies also have these workshops to train people. And I know if you look at I think the best sort of experience in low resource settings is the work from Chennai with Suchitra and her team, looking at echocardiography and how it is used to really as a, how would I call it, advanced monitoring to determine how you titrate the various drugs and those things. And I think Evelyn put something on the chat. Evelyn, is there an echocardiograph seminar at the WFPICCS?
Yep, we can check that and share that when we send out the recording, the webinar recording. We'll include that in the email if there's something in the program about that.
Okay, great. Thanks very much.
I think we're pretty much done with the questions. Dr. Tess, we would like to listen just as a summary on sepsis and early identification and management of sepsis. Just a couple of lines, and then
yeah, I think that these two studies illustrate also the very importance of early identification of sepsis, and early identification of sepsis and knowledge to treat depends on both education of the general population and education of families. I think that's important. And with early diagnosis, you're likely to be able to save about 90% of children with sepsis. I think, again, as I said, I would encourage everyone to go on the Global Sepsis Alliance and sort of join and contribute, give your input. It's all free. In April this year, we are having our annual conference. We usually have about 20,000 or more registrants from all over the world. It's free, it's online, and you can do it from anywhere you have in the world. Finally, for me, I think I'm very pleased to be here and to see so many of my friends from so many different parts of the world that I haven't seen for a while. And I really, truly enjoy this. I see Lincoln just put one thing about gut feeling of sepsis. And we did not discuss that, but that's a very important point. And the studies have shown that if a parent or has this gut feeling that the kid is critically ill, there's a relative risk, 36% chance of it really being true. And the gut feeling also is important with the clinician. We can't rely on that only, but I think the experienced clinician has this catalog in their brain, and they can look at pattern recognition, which I think leads to the gut feeling. So thanks very much, and I appreciate sort of seeing you all here.
So I would like to thank all our presenters, Carl, Shannon, Ashwardhan, and I would like to thank Dr. Preetham and Dr. Adrian Randolph for joining in tonight. And we're grateful to Dr. Tex to talk about this topic and emphasize on early identification and screening for sepsis and management of sepsis. So it's a very important topic, and a lot of countries are still struggling to identify sepsis early. And as you have seen in the cases, the case presented by Dr. Harshvardhan in India, so the child was treated earlier somewhere in a healthcare setup wherein the child had a focus somewhere in the head probably, and then ended up coming to his organization in Rainbow Children's Hospital further. So if you identify early and hit it hard, then I think you can prevent the fatal complications and outcomes of sepsis. So thanks everyone. Thank you again. And we would have a next leg of webinar in the next quarter. And we will have another topic and other experts joining in for the webinar. So thank you so much, everyone,
Thanks.
and thanks all the
Yep,
speakers.
thank you.